Perfect. Yeah.
Hello, everyone, and welcome to our final session of Prosthodontic webinar series with Prof. Faleh Tamimi. My name is Umar, and I am the webinar director at the SCORE committee. It's a pleasure to have you all with us today. Before we begin, I would like to introduce the International Association of Dental Students, IADS, briefly. IADS is the largest global organization representing dental students worldwide, connecting students from different countries and creating a platform for academic exchange, professional development, and cultural collaboration. The webinar is organized under the SCORE Office of IADS, and the SCORE stands for Standing Committee on Research and Education. It focuses on research, education, and international collaboration. Through SCORE initiatives, students have the opportunity to engage with experts, participate in global projects, and gain valuable learning experiences. And this is the final session of our Prosthodontic webinar series. We would like to thank everyone who joined us throughout this series, and we hope these sessions have been insightful and beneficial. We are also excited to continue our educational journey with the next specialty series, which will focus on oral and maxillofacial surgery. Without further delay, I would now like to hand over to my colleague Safiya, who will guide you through the next part of this webinar.
Hello everyone, I am Sofia, the webinar coordinator for today's session. It's a great pleasure to welcome you to the final webinar of our Prosthodontic series. Today we're honored to have our Professor Faleh Tamimi with us. Professor Faleh Tamimi holds a BDS degree from the University of Jordan along with 2 clinical certificates in geriatric dentistry and implant prosthodontics and a PhD in biomaterials from the University of Madrid. He has also completed his postdoctoral research training at Michael University. Dr. Faleh translated research program focusing on understanding fundamental problems related to health and disease in the oral cavity, while also developing new technologies such as biomaterial drugs and artificial intelligence to manage conditions like bone fracture, osteoporosis, and oral cancer. Professor Tamimi is a tenured professor and has held several leadership positions at McGill and internationally. He has received many recognitions and awards, including the Vital Dent Foundation Award, the Harry Rosen Award, the ACFD WW Wood Excellence in Dental Education Award, also a Canada Research Tier 2, and the Outstanding Research in Health Award from Qatar University. He has also received research funding from organizations such as CFI and CIHR and QRDI, and has published over 240 peer-reviewed scientific articles, many in high-impact journals. So we are truly honored to have you with us today, and all the floor is yours, Dr. Faleh.
Yeah, thank you very much, Safia, for the kind introduction. Okay, and thank you everyone for being here today. So today I'll be talking to you about like Omar and other colleagues asked me to give a talk about prosthodontics. So I'm going to talk about an area in prosthodontics which I've been working for some years now, which is the development of 3D printing technologies for removal prosthesis. I'm going to talk specifically about removal partial dentures, okay, and cast metal removal partial dentures with 3D printing technologies. Okay, so why partial dentures? You know, like in North America and Europe, for example, 13% of adults are partially dentulous, okay, and they're wearing a removal partial denture. So it's one of the most common dental treatments around the world, okay. And unfortunately, it's also one of the treatments that patients are less happy about. Okay, around 50 to 60% of patients with partial dentures are not really happy with their dentures. Okay, so it's an area of dentistry that it's very important because many people are having these treatments, but it's kind of neglected. You know, it's not like implants or other areas that there is much more happening there. Okay, so when you ask these patients why they're not happy with the dentures, you know, usually they say it's lack of retention, and that's very often related to, you know, problems in the denture itself, like they're poor quality or poorly designed.
Doctor, so sorry to interrupt you.
Yeah.
I think there's a problem with the sharing. Could you please try and reshare again?
Yeah, sure. Can you see now?
Yes, now we can. Thank you so much, Doctor. Thank you.
Good. Okay. Okay, good. So you can see my cursor. Okay. So partial dentures are kind of very tricky to make. I don't know if you remember from dental school, your lectures on how they are made. They're very complicated. You need to take a preliminary impression, you need to survey the model, then you need to take a secondary impression, okay? In the secondary impression, you need to block out undercuts, you know, then fabricate the design in wax, then you need to cast the wax. There is so many steps in fabricating a partial denture that, you know, researchers have found that there are around 243 possible errors that could happen during the process of fabricating a partial denture. So it's very technique sensitive. You need a very good technician to do it all right and not to commit an error, you know, so they're very tricky treatments to make. So how digitalization could help? You know, in the last 20 years in dentistry, there's been a, you know, increasing growth of the introduction of digital technologies, and these digital technologies that can help in many ways. Okay, so first of all, we can use optical scanners to scan models. Okay, and if we scan the model, we can do many things with an optical model. We can, for example, survey. Okay, so there are AI tools that you can use to survey models, identify the undercuts. Okay, even identify the optimal path of insertion. So this is a very good thing. Okay, so this has been around for 15 years. This technology. It was first developed by 3Shape, but it's been around for a while. Okay, so this is very nice. You can also use softwares in the computer to, for example, design a partial denture. Okay, so you could identify undercuts, blocked undercuts, design your framework in the computer. Okay. Okay, different parts of your framework. Okay, and you could have like a very nice design in the computer. Okay, so these possibilities have been brought up to by the development of intraoral scanners and improvements in software. Okay, the next thing, if we want to benefit from digitalization, is to transfer this into the real world. Okay, so I can scan my patient, I can design in the computer a partial denture. Okay, then how I fabricate this? Okay, so the first attempts to fabricate these partial dentures digitally was by printing those dentures in resin. Okay, so these are some images from a company I used to work with in Montreal. It's called 3D RPD, and they're among the first people that started to print partial dentures. Okay, so the way they did it is by printing the framework in something they call sacrificial resin. Okay, so these frameworks are made of a resin that will burn in the furnace, and then these frameworks they will cast them. Okay, and then they can produce metallic frameworks for partial dentures that are casted. Okay, but these were partially designed with the computer. Okay, so this is done with a simple 3D printer that is called a stereolithography 3D printer. Okay, it fabricates the resin frameworks and then we cast those frameworks. Okay, however, the company that was working on this 3RPD, they very quickly found that still you have issues with these frameworks because why? Well, because they are casted. Okay, and metal casting, it's a method that has it's been around, I think, for 5,000 years. Okay, so it's a very old technique that is it's very good, but it's not ideal. Because when you're injecting metal, very hot metal, into the investment material, many things could go wrong. The first of all, and the most basic thing is that when you're injecting hot metal, the distribution of heat in the metal is not homogeneous. So it's going to happen, you're going to have areas that are going to be hot and areas that are going to be cooler. So that's going to create shrinkage and expansions in the framework. So by default, the simple act of casting metal causes deformations in the framework. Okay, so it's impossible to have a perfect metal framework by casting. So what's the solution? Okay, so back in the 2010s, early 2010s, the metal 3D printing was introduced. Okay, so this is one of the first metal 3D printers that was commercially available, and it was purchased by a dental lab in Montreal. Okay, it's 3RPD, to start testing whether they could fabricate these frameworks by directly printing metal. Okay, so there is no intermediary resin or anything. You are printing metal directly. So you are printing the metal framework as it is. Okay, so you may ask, how can you do that? Okay, metal is metal. How do you print metal? Okay, so there is a very ingenious way of doing it. So you don't print the metal in a solid form. You print it in the form of powder. Okay, it's using a technique that is called laser sintering. So the way it works is that we can get powder of cobalt chromium, made of very small particles, like 20 microns, 30 microns, very small, And we can make a layer, a flat layer of these powder particles, and with a laser, we can weld those particles together, okay? So the laser can be operated through a computer, and so you can weld the particles in the right spots, okay? So here you can see an example. You see a layer of powder of metal, and here is the laser beam hitting the powder, and by doing that is welding the particles together. So in some areas, the particles are welded together, in other areas, the particles are loose. Okay, so if you have a machine that can create these layers step by step, so for example, with our roller, so you can add a layer of powder, and then you have a laser beam hitting the powder in certain areas, then you can add another layer, and you have the laser hitting the powder in different areas. So that way, step by step, within a piston of powder, you can build a framework, okay, of a partial denture. Okay, so this is how it works. Okay, so now a video of how the machine works. Okay, here you can see the laser beam is hitting the powder. This is all powder, metal powder. Okay, it's a bed of metal powder, and this is a roller. This is going to add another layer of metal powder, and it keeps doing that step by step. Okay, and then layer by layer, and at the end, then when you're done, you move the whole platform up, and you remove the powder that has not been hit by the laser, and here you can have all your frameworks. Okay, so you can have all your metallic frameworks. Okay, so this is how they look, the denture frameworks. Okay, so you go from something in the computer, from something in real life without any intermediary steps. Okay, there is no casting whatsoever. Okay, so how good is this? So we did some research, okay, about this technique, and it turns out that it's 8 times more accurate than casting and 5 times more precise. Okay, so it's way much better than casting in terms of precision and accuracy. Okay, so you can get very accurate frameworks. Okay, you minimize errors. So 8 times more accurate and 5 times more precision is quite a lot. We tested also the mechanical properties of these metals. So one of the issues with casting metals is that very often you get bubbles, and those bubbles could, in the structure, those bubbles could weaken the material. So we're expecting that this will be better than cast metal. Okay, so we did a 3D point bending test. Okay, to test the strength of these metals and their fracture, and it turns out that in effect, indeed, they were stronger. They were stronger than cast metals. Okay, so they were significantly stronger and tougher also. So they were more difficult to break. Okay, we look at the fracture surfaces of these metals. So these are the surface of the fracture area. Okay, and this is a metal that is casted, and this is a laser sintered metal. Okay, and you can see that they look very different. Okay, the cast metal, the fracture surface is kind of, random, right? There is no really order, but here you can see that there is a pattern. There is some order here. Okay, so the laser sintered metal, because we're adding the metal layer by layer, basically it's like you're building a brick wall for a house. Okay, the cast metal, basically all the metal is stamped, so there is no structure. So it's like as if you're comparing a pile of rubble versus a brick wall. Okay, so this in nature is very well known, that when you have organized structures mechanically tend to behave better. I'll give you an example. Seashells and chalk. Okay, seashells and chalk are both made of the same exact chemical compound, is calcium carbonate. Not only that, they are made of the same crystals, okay, of calcium carbonate. But chalk is much weaker than seashells. Okay, the main difference between chalk and seashells is the organization of the material. In seashells, the crystals are very highly organized. In chalk, the crystals are random. Okay, so this is something similar to what you see with laser sintered metal versus cast metal. Okay, and this became very apparent when we were testing fatigue. Okay, resistance to fatigue. So to do that, what we did, we tested, for example, what happens when you a clasp, for example, in a partial denture is engaged in undercut, it bends a little bit, right? So if you do that many times, it's going to bend a lot of times. And if the metal is not good, the metal is going to suffer from fatigue and it will become loose over time. So we tested that concept on a beam of metal, doing cycling clothing for thousands of cycles, So this is very similar to what engineers do when they want to analyze a structure for an airplane or a building or whatever. They want to make sure that the materials are good, not now, are good for thousands of cycles of loading. So that's what we did. We simulated that in the lab, and see what happens. So these are stress strain curves of cast metal after many cycles of loading. So this is, for example, the original stress strain curve, of cast metal. And these are after 600, 1,200, and 6,000 cycles of loading. So you can see that the metal changed completely, became much weaker. And these are the same graphs, but for laser sinter metal. And you can see here that they are overlapping almost exactly. So laser sinter metal, after 6,000 of mechanical loading, it didn't change at all. It was performing exactly like the first moment. This is the fatigue resistance over 6,000 cycles, and you can see that with cast metal it goes down over time, but with laser sinter metal it's very stable. The reason for this is that besides the organization of the material, which is very good for laser sinter metal, it has also another benefit. And it has to do with property of metals, which is the grain size. So metals, maybe you might be surprised about it, but they are actually made of grains. So metals are not homogeneous, even though you have a perfect metal at home or whatever metal you have. All metals in the world are made of grains. You don't see them usually when they're shiny, but if you put a little bit of acid on them, when you wash them, you will see the grain boundaries. So this is, for example, a piece of cobalt chromium that we etch it with a bit of acid, so we can see the grains. So you can see that, and we do the same thing for laser sintered metal. So you can see here that in the cast, the grains are very obvious. You can see grains of metal. They're very obvious. They have different colors, right? Each one of these shapes over here is a grain of metal. They're very big. In laser sintering, when you do the same experiment, the grains are tiny. So laser sinter, because we are hitting the very thin layers of powder every time. So basically what's happening is that the size of the grains of the metal are basically the thickness of the layer of powder that you're adding. So they're very small. These ones could be, close to 1 millimeter in size. These ones are microns in size. So usually in material science, when you have a material that is made of smaller grains, it's harder for cracks to propagate, because it's made of smaller grains, whereas materials made of bigger grains, cracks propagate easier. This is called the Hall-Page law in mechanical engineering. So this is, for example, the reason why you have a knife. The knife don't bend easily and they're very strong, and you have a wire. The wires are easy to bend, they can deform. So the main difference between a knife and a wire is the size of the grains. Like if you've seen movies, of ancient times where, there's someone making a sword. They will go with a hammer and they hit the sword with a hammer, and they hit up the sword and they hit it with a hammer or whatever. That's basically to make the grains of the metal smaller, so that the metal becomes much harder, stronger, and it doesn't deform, because if you go into a battle with a sword made of metal, you don't want the sword to bend like a wire, right? Otherwise, it would be completely useless. You want the sword to be strong, right? So that's why knives and wires, even though they're made of the same material, they behave differently. So this is something similar to what is happening with laser sinter metal. We're creating materials that are closer to the structure of a knife or a sword than to the structure of a wire. So that means that they are less likely to deform. So in a device that is supposed to function for many years, they're less likely to deform over time. Okay, we also did some tests on the biocompatibility of these materials. Okay, so this is just in vitro testing with cells, and basically the cells live in the they are as compatible as any other cobalt chromium alloy. This is one of the first studies we did with patients. Well, it's not a real patient; it's the dog of my friend, Dr. Caron. He was the chief scientist of 3RPD. So when we first got this printer, he tried it to make a crown for his dog. His dog needed a crown. So he took a scanning of the mouth of the dog. Okay, he designed this is the model of his dog, designed the crown in the computer, printed the crown, and he put the crown on his dog. So it worked pretty well. Okay, so that was patient number one. All right, so from these experiments, we found out that this method of fabricating dentures is very promising because you get very precise dentures that are resistant to fatigue, that they're tough, they don't break easily. Okay, and that's mainly because the way the metal is produced. Okay, so moving forward, we got a small grant, and we worked with. I decided to work with my colleague at McGill at the time, Dr. Jocelyn Fine. Dr. Jocelyn Fine is one of the pioneers of patient-reported outcome research in the world, okay, in dentistry. So we designed a clinical trial with her to test these dentures in patients and see the level of satisfaction of patients with these dentures fabricated with this technology. So the clinical trial was very simple. We get a model from the patient, okay, and that model we scan it, okay, and we fabricate a laser sinter partial denture framework, and from the model itself we can fabricate a cast partial denture. So for each patient we fabricate two dentures, one that is fabricated by laser sintering and the other one by cast. Okay, then what we do is that we give the denture, one of the dentures randomly, we give them to the patient, okay, for 4 weeks, and then after 4 weeks we switch and give them the other denture. Okay, wait for another 4 weeks. Okay, and then at the end of the study, we ask the patient which of the dentures they would like to keep. They will tell them, okay, you can only keep one. Which one would you keep? Also, different time points, we will give them a questionnaire. This is the patient satisfaction questionnaire developed by Dr. Jocelyn Fine, okay, to see how happy they are with their dentures. Okay, so during the study, the dentures were done using the same. The only difference was that the framework. One frame was laser sinter, and the one was casted. The rest was exactly the same. The dentures were done by undergraduate students, supervised by prosthodontists. And during this study, the dentist, the patient, and the technician were blinded, so they didn't know which patient was getting what. So, for example, the dentist didn't know. They only know this denture A, denture B, but didn't know which one was laser sintered. The same thing goes for the patient and the technicians that were involved in fabricating that. Okay, so these are the patients that were involved. So we had like 12 patients recruited. Okay, some of them they started with casted and then ended up with laser sintered dentures, and some of them started with laser and ended up with casted dentures. Okay, we have a different range of types of dentures. We have some Kennedy class 1, class 2. We have some in the upper, some in the lower. Some patients have both. We have a mix of males and females. Okay, so these are the results of the survey. Okay, so this is the scores of the patients for different questions in the survey. So orange is laser sintered dentures, blue is the cast dentures. And these are different time points, week 1, week 2, week 4, okay? So you can see that in every category, in every single category, the laser sintered dentures were scoring higher than the cast dentures, okay? General satisfaction, easy of cleaning, ability to split, comfort, stability, ability to chew, chewing efficiency, oral condition, everything was higher for laser sintered dentures than for cast dentures. But the only exceptions And this was kind of expected because the aesthetics they don't depend on the framework, depend actually on the acrylic teeth, which were identical in both cases. So this was kind of expected. Okay, and when we ask the patients which denture they prefer, the majority prefer the laser sinter denture. Okay. The main reason why they prefer the laser sinter denture, they used to say because they felt that it fit better and it was tight and lighter. One patient only preferred the cast, and he said that it was less painful. Probably the denture was too tight for him. We also quantify prosthetic complications and complaints from the patient. Okay, and again, there were many more complaints and adjustments needed in cast dentures than in laser sinter dentures. Okay, if you want to put in context the satisfaction of patients in our study, okay, most studies in the literature, the satisfaction of patients with partial dentures, it goes between around 50% to 70% maximum. In our study, the cast dentures, the patient satisfaction rate was around 70%, which is similar to the rest of the literature. But with laser sinter dentures, it was around 86%. So they were much more satisfied with laser sinter dentures than with cast dentures. Okay, so patients are very happy with these dentures. Okay, so we mentioned that digitalization can help us design in the computer partial dentures, and that allows us later on to 3D printing, the dentures. Okay, another thing that digitalization allows us to do is that, okay, because now we have the patient in the computer, we could actually do things that were impossible before, which is actually engineering the structures. Okay, we could actually optimize the structures for mechanical optimization. Okay, so what we did with a team of mechanical engineers, we started to model in the computer and figure out the equations of how a dental clasp actually provides retention. Okay, so the way a dental clasp provides retention is because the clasp bends a little bit when you place the denture in. Okay, and it engages an undercut, and by engaging the undercut, okay, it creates some friction, okay, with the surface of the tooth. Okay, and that friction keeps the tooth in place, the denture in place. This is a simulation in the computer of what happens to a clasp when you engage an undercut. Okay, and this graph over here is showing deflection. Okay, how much it's bending. Okay, so the tip it's bending quite a bit because it's engaging the undercut every time it goes in and out, and this is a mechanical stress on the clasp. So the area of the clasp that is engaging the minor connector, it's undergoing very high stress. Okay, very, very high stress. So this is a simulation of a very simple clasp in the computer, and you can see that in this area here there is a lot of mechanical stress just by putting the clasp in and out. This number of the magnitude of the stress here, it's 787, is higher than the safety limit of cobalt chromium. So this basically means that circumferential clasp that is made of cast metal, just by putting it out over the years, it's going to be subjected to this force, and this force is sufficient to cause deformation over time. Okay, so a circumferential clasp has a very big chance of changing over time. Okay, these are the equations developed by the engineers to figure out that deformation in the clasp. Okay, and this is the results of simulations in the computer based on those equations on how different shapes of clasps perform. Okay, and in this particular example, we're talking about circumferential clasps. So the colors indicate the mechanical stress, the maximum mechanical stress that's happening in the clasp. Okay, this axis over here is the length of the clasp, how long it is, and this is how thick it is. Okay, if you have too much stress, it's not good. This clasp is going to deform. Okay, too little stress, the clasp is going to stay good. Okay, so this graph basically what it's telling you is that, the blue area, which is actually the safety area, the safety margin of cobalt chromium, is this part over here. Clasps do well if they have a diameter of 1 to 1.2 millimeters, and if they are around 9 to 12 millimeters in length. We don't have information about shorter clasps, because at shorter clasps the equations fail, okay, because they don't work. Okay, so basically what this work was showing us is that with laser sinter clasp, and by default also the cast, I think it's the same problem, is that they could work, but only in teeth that are large. Okay, so basically what this is telling us is that, okay, we can optimize the shape of a circumferential clasp, but circumferential clasps are not going to work on premolars or anterior teeth or canines, okay, because they will deform very quickly. Okay, so superficial clasps, they're good for molars only. We did a similar thing for I-bar clasps, okay, and I-bar clasps, the situation is different. They do work in short teeth, okay, so here we have the safety margin, and this is the length of one arm of the I-bar clasps and the length of the other one, okay, so you can see that here, when they are small, the clasps perform pretty well, providing very good retention. So I-bar clasps, not only they're nice and aesthetic for anterior teeth, nicer than C-clasp, they're actually mechanically safer. Okay, they're not going to deform over time. And you can check this with patients or with your doctors, your supervisor. They will always tell you that, I-bar clasps, you rarely need to adjust them. But C-clasps, you need to adjust them very often. Okay, and the reason is because, before this study, we didn't know that, but circumferential clasps on anything that is not a molar, they are gonna deform over time. They're gonna get loose, and you will have to adjust them. Okay, so the patient is never gonna be happy with a circumferential clasp on a tooth that is not a molar. Okay, I-bars, on the other hand, they're mechanically very good for anterior teeth. For posterior teeth, they're not good. Okay, so and all these things that I'm showing you, we know not because we just tested in the computer, because we actually printed those clasps and we tested them in the lab, with mechanical testing machines. Okay, so we know that they work this way. Okay, so basically, digitalization allows us to fabricate partial dentures in a more precise way, okay, with better quality materials, and also it allows us to optimize the shape of those materials. We can actually not only make better materials for these dentures, but also smarter designs, more optimized designs. Okay, another thing that, another question when you design a partial denture is, okay, how many clasps should I put? Where should I put the clasps? How do I design the framework? And in dental schools around the world, we teach you guys how to do that, right? And we try to pretend as if it's an easy thing, but the reality it's not, okay? Because then partial dentulism is something that is very unique to each patient. There are around 65,000 forms of partial dentulism. Okay, there is no two patients that are the same. Okay, the chances that one tooth is missing or present or absent, okay, and the probabilities are 65,000. Okay, so it's impossible to have clinical trials on every single type of dentulism, okay, or getting trained or experience on how to do each one of these types of dentulism. So after doing the 3D printing and optimizing the class design, we decided that, okay, we want to also figure out how we can optimize the frameworks. Okay, so one way of doing it is with AI. Okay, so you can just give thousands of frameworks to AI models and train them so they can just mimic whatever people have been doing. The approach that we follow was a bit different, was based on mechanical engineering. So basically, we came up with hypothesis. Okay, we say, and the hypothesis is the following: when we design a denture, we want the denture to be retentive. Okay, and how we define how retentive should it be? So our definition of how retentive should it be is that it should be retentive enough so that the patient eats, the denture doesn't come out. So what forces affect the denture, okay, when the patient is eating? What forces could make it come out? Okay, so it's the masticatory forces. Okay, so basically our hypothesis is that the clasps should provide forces of retention that are equivalent or higher than the forces of mastication that are happening. Okay, so we want to test that in the lab. We can fabricate a denture. Okay, we can put a clasp here, for example, and we put some food here. Okay, and basically the forces of the food pulling denture out should be smaller than the forces of the clasp that is trying to keep the denture in place. Okay, and this applies in the lab or in a patient. Okay, so that was our hypothesis. Okay, so we test the hypothesis first in the lab. Okay, so these are some dentoforms. Okay, and we put some food on the teeth. Okay, different types of food, and we tested how much retention, how much forces of tension the food is causing on the teeth. Okay, so there we go. So we put some food. Okay, we do some mechanical testing. We measure the force here. Okay, so much force each piece of food is putting in. Okay, we tested this with different types of food like candy, chewing gum, bread, whatever, and then different types of occlusion, class 1, class 2, class 3, and then different types of teeth, anatomical, non-anatomical. Okay, and then we did the same test for clasps. Okay, so we tested 3 types of clasps: sequential clasp, rod-wire clasp, I-bar clasps. Okay, and for the clasp, what we did is we test them mechanically after many cycles. Like we test them once, and then after many cycles to see the retention of the clasps over time. I'll do that for different teeth. Okay, and based on that information, we created tables like this of tables of the retentive force of the clasps and the masticatory forces. And with those tables, we can create a very simple equation. Okay, that the retention force of the RPD, okay, is the retentive force of all the clasps minus the chewing tensile forces of the teeth that are being replaced. Okay, and ideally, it should be higher than 0. Okay, if the retentive force of the clasps is higher than the masticatory forces, the denture is going to stay in place. If not, it's going to be negative, the denture is going to come out. Okay, so just give an example. This is a case of partial dentulation. These are missing. Okay, so these are the forces of tensile force that food is going to produce on this acrylic teeth. Okay, so in this case, it's 36 newtons. Okay, so if the patient is eating, okay, there is 36 newtons of force that is going to come from this acrylic teeth. Then we can do the same thing for the clasps. Okay, so the clasps, we know that different clasps, a rod-wire clasp, for example, produce 13 newtons more or less in each one of these teeth. So in this case, if we put 3 clasps, the total retentive force is 39 newtons. Okay, 39 newtons is higher than 36. So that means that, this design, putting 3 clasps, should be enough to keep the denture in place. Okay, so we test this experimentally in the lab. So we created randomly in the computer 30 different cases of partial dental lesion, and we created 30 different random designs for those cases, and then we tested whether they were retentive or non-retentive based on our calculations. Okay, so we found that our model was very specific, 100% specificity, 92% sensitivity, and 97% accuracy. So this is based on lab information. So after testing in the lab, we went ahead and did a clinical trial, okay, with patients. So this is 75 patients that were recruited in a clinic in France. And we get them to fill questionnaires of their satisfaction with the partial denture. And we got their models, and so we also could calculate if the models were retentive enough or not. Okay, so we saw how many are predicted to be satisfied and were happy, how many were predicted to be unhappy and were happy, and how many were predicted to be happy but that they were dissatisfied. Okay, so basically what we got is a specificity of 83%. Sensitivity was low and accuracy was not as high, but the specificity was quite high. So that means that if we have a scenario and we test it with our equation, and the equation tells us that this is good, so 83% of the time the patient is going to be happy. So it's kind of good in predicting what you are designing. Nonetheless, there are some patients that you give them something that is not good and still they are happy. Okay, so this is what happened in this situation. So we're having many cases that patients were happy even though the denture was not very retentive. Okay, because it's patient satisfaction is a bit psychological. But anyway, the model is good in predicting a good design. Okay, so this method allows us to design in the computer partial dentures that are predicted to be more retentive. We created a website, okay, so you can, it's free, this website. You go on this platform, it's called ebhnow.com. There is a tool there, it's called RPD Tester. So you can use it to test if your design is retentive or not. Okay, so now in the last few minutes of the lecture, I'm going to talk about, okay, what happens after all these studies that we did. Okay, so 2 years ago, the editor-in-chief of Journal of Prosthodontics commissioned me to do a systematic review on all the work that's been done after we started our work on digital partial dentures on the subject, okay, to see what's now the level of evidence on the use of 3D printed partial dentures. Okay, so we ran a systematic review with meta-analysis on looking for studies that people have done after our work on 3D printed partial dentures, okay, and laser sinter partial dentures to see how the level of patient satisfaction. Okay, so we found 2 studies that look at patient satisfaction, and in both those studies, patients were more satisfied with 3D printed partial dentures than with the traditional ones. We also look at studies that look into framework fit accuracy. There were 4 studies that look at framework fit accuracy. In all of them, patients were the fitting was better in 3D and laser sinter partial dentures, and the meta-analysis showed that it was also producing better results, and it was significant. Okay, so in summary, digitalizations have allowed us to transfer, the mouth of the patient to the computer, okay, with the help of intraoral scanners. And with computers, now we can design in the computer the dentures, we can automate those designs, we can optimize those designs, and then we can use 3D printed technologies to transfer those designs into real-world dentures that work very well with patients. Okay, so I'd like to thank all my collaborators and former students that work in these projects along the many years, like Eric Alon from the company 3RPD that sponsored these studies, my colleagues from McGill, Jocelyn Fine, and Yun Son, mechanical engineer from McGill, Dr. Emmanuel Nicolas, is now the dean of the University of Clermont-Ferrand in France. He's a prosthodontist that did some of these studies. And my PhD students, Omar El Aguil and Balkis El Mufleh from Riyadh. Now they are professors in Riyadh in dentistry. And then Dr. Omar El Shegri, he was also my student. He's a mechanical engineer, and he's a professor in King Fahd University in Dammam. And thank you very much for your attendance. So I'm open for any questions.
Thank you, Prof. Faleh, for your engaging session. So we are opening. If there is any question you can ask, and are some questions. In which cases would you still prefer the conventional technique over the digital workflow?
So regarding removal partial dentures, I think the evidence we have is that, well, unless you don't have a lab that produces a 3D partial framework, okay, or you're living in a situation in a setup that there is no access to these technologies, then the regular workflow is fine. It is what you have access to. But if you have access to 3D printed dentures and economically they make sense to you, then they are superior. Yeah.
Okay, thank you. And there is another question is saying, what are the most common challenges when using intraoral scanner for partial edentulous cases?
So in the studies that I was showing you, well, this is a very good question. So in like intraoral scanners, they were originally invented for teeth. Okay. So when you are working with someone that is edentulous or partial edentulous, the intraoral scanners they sometimes they struggle because they, in order to the way they generate the 3D image is by stitching many photographs together. So they have these AI softwares inside that they try to find for references in the photos that they could use them to stitch to each other. So in teeth are excellent for that because they are solid. Okay, so you can have a picture of the tooth from one angle, then you have a picture from the tooth from another angle. We stitch them together so we can build the whole model. Okay, when you go to soft tissues, that's harder. Okay, soft tissues are and if you're going to the vestibule, which are soft tissues that are actually moving on top of that, it becomes even harder. Okay, so there is many research around the world that are trying to figure out how to use intraoral scanners for partially edentulous or complete edentulous cases because you need to capture the soft tissues. You know, some areas are the palate, you can do something about it. The mandible, especially the lingual vestibule, is very hard. Okay, so in the studies that I was showing you, actually they were done with regular impressions that were scanned afterwards. Okay, so the dentist will take a regular impression, they will scan it, and then they will scan the model, and then they work on the model. Okay, so doing the full digital workflow is an area of research currently. It's not there 100%. Like people are trying, there are companies that are working on the software to improve it to get there. And eventually we'll get there. Okay, so I actually do now a project, some people in the University of Dammam to get that to work. But yeah, it's not easy.
Okay. Thank you, Dr. Faleh. Thank you very much for this insightful and engaging webinar. We truly appreciate the time and the effort you dedicated to sharing your valuable knowledge and experience with us today. Thank you, Doctor. Thank you once again.
You're welcome.
Thank you. Dear participant, on behalf of the IADS Score Webinars team, thank you for being with us today during this series. We hope to have you the opportunity to welcome you again in our upcoming oral and maxillofacial surgery webinars. And kindly note that the QR code for attendance will remain visible on the screen for 5 minutes to allow participants to scan it and complete the form. Thank you, everyone. Thank you and bye-bye.